So hi everyone, and welcome to what I imagine will be a wonderful webinar. We're very lucky to have an excellent speaker here today. So this webinar is titled Undertake Implementation Trials, and it's being hosted by the Centre of Research Excellence in Treatable Traits. So I'm Rebecca McLaughlin, I'll be chairing this session today. Before I do introduce our speaker, I'd just like to start by acknowledging the Pemberton clan of the Wolfenden people, who are the traditional owners of the land on which we're speaking to you from today. I'd also like to acknowledge the traditional custodians of the lands on which each of you online have joined us from today. And I'd like to pay my respects to elders past, present and emerging. So we're very fortunate to have Professor Luke Wolfenden here today to give us a talk about implementation trials and all there is to know about implementation research. So Luke is a behavioural scientist. In 2013, he commenced an MHMRC Career Development Fellowship. He graduated with a PhD in behavioural medicine in 2006. And since the submission of his PhD, he has worked with internationally recognised research institutes such as the UK Cochrane Centre and was an invited visiting fellow at the World Health Organisation. Nationally, he has been primarily responsible for the evaluation of Australia's largest ever obesity prevention program, which is the Good for Kids, Good for Life, where he led the research collaboration between the Prevention Research Centres of the University of Sydney, Huntington England Health Service and New South Wales Health. So before I do hand over to Luke, I just wanted to say that we will have question time at the end of this presentation. So for those of you who are online, if you would like to pop any questions you have into the Q&A box, and we'll see them after Luke's presentation. So I'd just like to hand over to Luke now, so thank you, Luke, and welcome.
Thanks, Rebecca, and thanks for having me. I'm delighted to be here. I'll just also start by acknowledging the traditional owners of the land that we're meeting on today and pay my respects to elders past, present and future. And also welcome any Aboriginal and Torres Strait Islander colleagues with us today. So yes, I'm presenting on implementation trials designs. As Rebecca said, I'm more than happy to answer whatever questions you have at the end of the presentation. I guess there's some assumed knowledge here in terms of clinical trial design, but I'm trying to provide a bit of an introduction to implementation science and how those two might come together. A couple of useful resources for people that might be new to the field of implementation science or the conduct of implementation trials. There was a supplement a couple of years ago that provides an overview of research and evaluation designs for dissemination implementation research. So we published a guide on this in the BMJ in 2021, and there are also some great resources through Cochrane via their effective practice and organisation of care that people can take a look at if they want to find out a little bit more. So implementation trials, what are they and when should they be undertaken? I'll just start with some basic terminology around implementation science. So evidence-based intervention is an evidence-based practice, model of care, program policy or other guideline that is recommended is being implemented. So when we talk about the EBI of evidence-based intervention, it's the thing that you're wanting a clinician to implement or deliver as part of their usual policy or practice. Implementation science is the study of methods and strategies to promote the uptake and integration of evidence-based interventions into routine policy or practice. So it's the science of how that process occurs. Implementation strategies are methods or techniques used to enhance adoption, implementation and sustainment of an EBI in clinical practice. And so these are kind of, sometimes they're referred to implementation interventions, or the things that the thing that you do to get the evidence-based intervention into policy or practice. Implementation outcomes are usually processes of care or quality measures. I'll describe these in a bit more detail in the presentation. That really to assess the effects of an implementation strategy. And an implementation trial, we're talking about today, really test the effects of implementation strategies to get an evidence-based intervention to policy or practice on implementation outcomes. So how do they differ from conventional clinical trials? So in a conventional clinical trial, the efficacy of an intervention is not known, and so you're conducting a clinical trial to assess the impact of that intervention on a clinical outcome. And so this could be, the intervention might be a therapy, a surgical procedure, or a public health program, and you're really looking at health benefits as a result of those outcomes, often at the patient level, sometimes at the community level. So it could be a change in blood pressure or a change in a particular health behaviour for a public health intervention. For implementation trials, the efficacy of the intervention, as I mentioned before, is known. So you're not retesting that. You're starting with an intervention of known efficacy. What you're testing is how you can get that intervention into policy or practice. So you're testing the impact of an intervention strategy of an implementation strategy on the adoption or integration of care of that policy program. So the outcomes that you would typically use in an implementation trial would be around measures of quality of healthcare, the use of clinical practice guidelines, basically. So a conventional clinical trial is really looking at the relationship between intervention. This is a workplace health promotion intervention. So it's really looking at the relationship between intervention in this case example, employee health behaviour, so that individual health outcome. Whereas an implementation trial, we know the intervention works, I'm not interested in reassessing that. We're primarily interested in how we can implement that workplace program with sufficient fidelity that we can retain its impact on, in this case, employee health behaviour. So it's really looking at the relationship between the implementation strategy that you use to do that and the level of implementation that occurs as a result. Because we know implementation trials don't achieve fidelity is still an issue in implementation trials, sometimes we're also interested in assessing its impact at an individual level. So we might also assess, in this example, employee behaviour. And when we do that, we call that a hybrid trial. So we're measuring both implementation outcomes and individual level outcomes. So when is an implementation trial warranted? So we developed this kind of schematic to help this process. Essentially, you need to go through a few steps to assess whether an implementation trial is needed. When health services looking to address a particular health problem, they should really be looking to systematic review evidence to identify whether existing evidence-based initiatives or policies or programs exist that are effective in addressing that outcome or that issue that you have. And if that's the case, we need to make sure that that policy or therapy or procedure isn't routinely already occurring in practice. Because if you have an evidence-based intervention, it's already in practice, it's already routinely occurring. You don't need an implementation strategy. You then need to look for whether, like when you look for an effective intervention, you need to also look at systematic review evidence to see if there are existing effective implementation strategies in implementing that evidence-based intervention. So it's exactly the same process, just applied at a different level. And if there aren't any effective implementation strategies for that particular intervention, then you will conduct an implementation trial to try and generate evidence for the strategy that you're looking to test. Okay, so I'll just now kind of step through the key methods or the key steps in undertaking an implementation trial, starting with the articulation of trial aims. So, like any good clinical trial, you need to have an aim which is a precise statement which includes information about the population, the implementation strategy, the comparison, and the outcome under investigation that you're looking at. And to support this, there are implementation trial guidelines called STARI, and they recommend that as part of the aim, you distinguish between the aims of the implementation strategy and the therapeutic intent of the intervention, of the evidence-based intervention that is being implemented. So for example, if we're looking at using a nicotine replacement therapy as one example, we might have a study where the primary aim is to assess the effectiveness of auditory feedback, which is an implementation strategy, relative to usual practice, which is your implementation comparison, for improving clinician, which is your population provision, which is your implementation outcome, and the targeted implementation strategy of nicotine replacement therapy. And nicotine replacement therapy is a clinical innovation. For hybrid designs, where you're also looking to assess the impact of that implementation approach on a clinical outcome, you might also add a second component to that statement of trial aim, which would be to also, you're also interested in assessing the effectiveness of nicotine replacement therapy in clinical intervention relative to usual care in improving smoking cessation, which is the therapeutic outcome and the therapeutic intent of that clinical intervention among cardiac inpatients in the population. So sampling, recruitment and retention strategies. So strategies to improve, implementation trials often require participation at multiple levels. So you're not just interested in the patient here, you're looking to change some system of care so that the system is conducive to the provision or improvement of healthcare or practice. And so you often need to recruit organisations, outpatient clinics, schools, hospitals, that are willing for you to work with their usual workforce, their healthcare workforce, and to engage in strategies to support clinical practice change. You often include measures, so often your implementation outcome measures are directed at staff, so these could be clinicians, or in the case of the school teachers, because it's typically their practice that you're looking to change. You're wanting them to implement something or deliver something in a different way or in a better way with their patient, or in the case of a teacher, their students. You often have measures, you often need to recruit staff into that study. And if you're doing a hybrid trial where you're looking to collect information not just on implementation outcomes, but individual outcomes, you'll also need to recruit patients. Implementation trials are inherently naturalistic and pragmatic. They're not looking like a typical efficacy trials looking to screen out patients who might respond well to a therapeutic intervention. Implementation trials are really undertaken under real world context, because that's the context that you're trying to change. There's not actually a lot of good research that's been undertaken to date to identify how you can recruit into implementation trials, particularly at the more macro level, so how to recruit hospital sites or clinicians into research trials. Most of the evidence-based strategies to increasing recruitment rates and minimising participant attrition have really been directed at patients. So there's large systematic reviews and meta-analyses around effective trial participation and attrition strategies. And I guess the recommendations to date is that when we're doing implementation trials, we have a look at the attrition and participation evidence base for clinical trials and see if we can apply those strategies or amend or adapt those strategies for targeting different participant groups. Okay, selecting research trial design. So today, I'm really just talking about randomised controlled trials and variants of randomised controlled trials. I'm more happy in discussion to talk about different trial designs that might use non-randomised assignment. But when we're doing implementation trials, there are a number of different trial designs that you can select. A typical parallel group randomised controlled trial is kind of the gold standard for drug development and other therapies. It's often very hard to apply this in an implementation trial situation, and that's because usually in an implementation trial, you're trying to change, as I mentioned, the system of care or the operation of an entire clinic. And so you kind of can't get around this issue of contamination. You can't assign individuals. And so usually in implementation trials, the most common design are cluster randomised trials where entire units are randomised to receive an implementation support strategy or from the usual care or alternative implementation support strategy. So they are clearly the most common design, closely followed by step wedge trials that often work really well for implementation questions because they often follow the process in which programs are often rolled out into clinical or community settings. It's often done in a step-based fashion. So harnessing the natural program delivery structure and nesting in that or using that as part of an experimental design to evaluate its impact is also very common. There have been individual randomised controlled trials or factorial randomised controlled trials to assess the outcomes of discrete implementation strategies like audit feedback, where individual assignment is possible. So, for example, Jeremy Grimshaw's done a lot of work looking at providing audit feedback to clinicians in different ways to improve prescribing behaviour, as one example. And they've been able to use large numbers of participants being clinicians, through national prescribing services to really optimise how audit feedback as one strategy is provided to clinicians to maximise its impact. We also have these sequential multi-assignment randomised controlled trial designs that are really looking to develop adaptive implementation strategies. So based on response to a particular implementation approach, a new implementation approach is introduced. These are also kind of quite sexy in the field, but aren't applied very often because it's quite a challenge to assign participant, the various participant groups in an implementation trial in an adaptive way. And then we have non-randomised designs, which are most appropriate when random assignment is not possible, or as an opportunistic design to assess the impacts of a naturally occurring event in the context of a natural experiment. I will say, often I hear when people talk about implementation trials, that randomised assignment or randomised controlled trials are not possible and often shouldn't be used. Randomised controlled trials are clearly the dominant design in the field of implementation science, and so non-random assignment is actually uncommon, at least in the published literature. It's heavily dominated by random assignment, and there's good ethical reasons why that might be the case. Okay, the field of implementation science has seen an explosion of theories to support the conduct of implementation research, to the point where it's actually complicated to try and understand which theory or framework you might use for different aspects of developing an implementation strategy or undertaking an implementation trial. However, the use of a broad or the articulation of a clear program theory for your implementation strategy that you develop and indeed the broader trial is really important. And the lack of explicit descriptions about the mechanisms by which implementation strategies exert their effects on the outcomes that they're targeting is a real impediment to the field. So we don't have a good understanding by which the mechanisms of these implementation strategies exert their effects. So while we have lots of theory, we don't have much to actually say these theories are any good at improving the outcome. So implementation trials should include an explicit program theory that details the rational assumptions about the mechanisms linking the implementation strategy and the invention, and the processes and inputs into the trial outcomes. And so your program theory can be developed through the use of informal theory, and by that we mean really the processes, the co-production processes which really engage the clinicians or the site that you're looking to work in to get their understandings about what support might be needed to improve clinical practice and what their current barriers are to improvement. And so they will have a really good idea about what might or might not work in their context, and that can be used to develop a program theory of what you're going to do and how it's actually going to work. It's also recommended that you do use formal behavioural or implementation science theories or frameworks, because that can provide a broader perspective on the theoretical thinking about the mechanisms or linkages between particular strategies and processes of improvement. And for implementation trials, the reason program theory and logic models are so important is because it's the skeleton or scaffolding for your entire trial. So depending on your program theory, if you've got a clear program theory, then all the outcome measurement selection becomes really simple, as does an understanding and a description of why and how the intervention might have worked, or the implementation strategy might have worked. Just an example. And so there are a number of websites that have been developed that have kind of tried to catalogue the various implementation science theories and frameworks. This is a good one that's been supported by the National Cancer Institute in the US. I think this is actually an old screenshot. The website's been upgraded since I created this slide, but this website allows you to sort through the theories and frameworks depending on what it is that you're actually looking to undertake. Okay, I'll talk now about selecting outcome measures. So your outcome measures in an implementation trial should be directly linked to the primary and secondary aims of your implementation trial. Hybrid trials need to include, hybrid trial measures need to be included to assess implementation outcomes and individual health outcomes. So your outcomes, like in any good clinical trial, should have evidence of validity. So it's clear that you're measuring something accurately and what you think you're measuring is indeed what it is you're measuring, and be sufficiently sensitive for change for inclusion in a randomised controlled trial so you can demonstrate benefit if you indeed see improvement. In the field of implementation research, there is a paper by Elaine Proctor which describes 8 implementation, they're called outcomes. I've changed the language here to measures. 8 implementation outcomes that could be considered in implementation research. And for implementation trials, I've seen people just try and just include these 8 measures in every implementation trial that they do. And often they're trying to contort some of these measures, which are really supposed to be, in many cases, within group measures, not between group comparisons to assess effects. And so we think this has been tremendous for standardising practice and understanding and defining measurement issues for the field. But really, when you're conducting an implementation trial, the primary outcome is really some measure of quality or process of care. And then you have a range of other outcomes, including some of the measures here that have been defined by Proctor to try and help you understand any findings that you might get as a result of the trial, so any changes in improvement practice. So they include things like acceptability, adoption. So adoption is not the implementation of a program, but an agreement or an intention to undertake change by a clinician or by a manager of a particular department. Appropriateness, which is the perceived fit or relevance of the intervention. Costs, feasibility, fidelity, so the degree to which an intervention was implemented as it was expected. Penetration, which is often in public health, we often use the word reach, but penetration is the integration of the degree to which the intervention is integrated into practice within its service settings and subsystems. So it's kind of the degree of integration, and they call it, there's measures of kind of vertical integration where an intervention, for example, is included in routine procedures at a very local level, but there's also changes that might happen across the workforce system and the policy at a policy level, so you can see that there's a high level of penetration or integration of that intervention into policy or practice. And finally, sustainability, so it's the extent to which a newly implemented intervention is maintained or institutionalised. Okay, so when we talk about process evaluations, the Medical Research Council suggests the key functions of a process evaluation include its assessment of processes, mechanisms, and contextual factors that might shape the outcome. And there's been a range of kind of guidance in the broad field of implementation science to provide some recommendations about how this should occur in the context of conducting an implementation trial. So when we talk about implementation processes, we're really looking to measure here how, what, and by whom the implementation strategies were delivered and received. It's a bit like a typical process evaluation in a clinical trial to make sure that the intervention, you often measure, was the intervention delivered and received, delivered as it was intended and received by who it was intended for. Because if that doesn't happen, then you can't really attribute the effects of the clinical trial to the intervention if it wasn't delivered sufficiently. You also want to include some measures of co-intervention or receipt of other interventions or implementation support that might be found. We're finding assessments of adaptation. So what we do know in implementation science is it almost doesn't matter what is, what new health innovation is expected to be delivered or introduced into a health system. Adaptation, so changes to that, particularly at a local level, is ubiquitous. It happens all the time. And that can have a profound impact on ultimately the therapeutic benefit of that intervention to the patient. And so there are a range of frameworks to try and assess what, not whether, because it's almost always something's happened, but what adaptation has occurred in the context of the implementation of a particular intervention, and whether that adaptation is likely to have an adverse impact of the intervention on the ultimate intended therapeutic outcome, or whether it was fidelity consistent, and sometimes it actually enhances the impact. Adaptation also often occurs to increase fit or relevance of the intervention into the local service setting. And so sometimes, for example, interventions that were intended to be delivered in a face-to-face might be delivered online, for example. Sometimes the number of sessions might be reduced, sometimes additional kind of co-interventions are added in the context of a broader package of care. So getting a good assessment of adaptations and what occurs is important in the context of an implementation trial to help you explain the effects that you observe. And then there are a range, for the Proctor measures that I mentioned before, there are a range of repositories of validated instruments to measure some of those constructs. So there are validated instruments to measure acceptability of progress. One of those is the Society for Implementation Research Collaborative, or CERT, have an instrument review project, and they surveil the literature and find new measures, and then we've got a rating scale for each of the measures to help people select, to identify which measures are valid and reliable and pragmatic, and people kind of work through that and select ones that best fit their needs. So mechanisms of impact. I mentioned before it's important to understand how implementation strategy effects might be replicated and improved and test causal assumptions, and that doing this requires a clear specification of strategy mechanism linkages. There are some, usually when you're developing your program theory, I mentioned before, we recommend that you, as well as the tacit knowledge from clinicians or service staff at the coalface, that you also incorporate the use of existing theoretical frameworks in the development of that theory of change. Usually, as part of that theory of change, you will have some factors that you're looking to change that mediate, that you're hypothesising mediate the effect of improvement that you're looking to observe. And these are typically theoretical, and you can, based on whatever theory or framework that you use, you can usually select those theoretical constructs that you're hypothesising would lead to the improvement that you're wanting to see, and measure those as part of an implementation trial. And that's a CERT repository that I mentioned before. Also includes measures of theoretical constructs that are important for understanding implementation processes. And of course, qualitative or mixed methods approaches are also particularly useful. And these approaches have got much more pragmatic recently, so there's a string of work in implementation science around rapid qualitative inquiry, consistent with more learning health systems approaches to improvement, and that often involves embedding qualitative researchers in clinical settings to observe change as it happens, and that is actually a fantastic surveillance system to then feed back information about what's working or not in the context of the operation of the trial, rather than waiting for the trial to finish and working out something.
Is that like an ethnography or something?
Like ethnography, yeah, rapid ethnography. And finally, implementation context. So this context is also a very often misused word or misunderstood word in implementation science. Everything is contextual. But when we talk about context, we're really referring to factors that may influence the effects of an implementation strategy. These may include measures of social, political, economic environment that may influence implementation. So it could be the nature of the workforce that you're working in, so their readiness to change. It could be the existing implementation infrastructure. It could be the introduction of a large hospital-wide policy that represents a large disruption for the service that you're working with. So having systems to identify what contextual factors are important for your particular project is important, and then systems for measuring and capturing that information and describing it alongside your primary and secondary outcomes. So implementation context is typically descriptive and not analytically presented in reports or documents. And so this is just a screenshot of the CERC measures database. Okay, and finally we have reporting guidelines. So obviously the primary reporting guideline for an implementation trial is based on the research design that employs. So if you're doing a randomised controlled trial, you should be reporting implementation trials as you would any other clinical trial using things like the consort statement. We also have, implementation science also has its own reporting standard called the STARI guidelines, that there is an expectation, at least in implementation journals, is also coupled or submitted alongside your consort checklist. You probably can't make out much of that text. But essentially it often looks for you to describe and disaggregate the thing that you're wanting to implement, so the evidence-based intervention and what it's trying to do from the implementation strategies that you're using to try and get that thing implemented. So unlike a clinical trial where a researcher will just often come in and deliver the intervention and your fidelity is assured, implementation trials are really looking to disaggregate those two things because they're examining them differently. And maybe one other thing to mention is that there are the Equator Network houses a range of reporting guidelines, and although we have STARI, there are kind of some other, there's another guideline that's coming to scale up, which is similar to implementation, but just not quite identical. So there's another guideline for that. So even if you don't use them, those type of guidelines can be useful for planning your study because they just provide, they're often accompanied by good explanatory documents that justify the inclusion of those, each of those reporting criteria. Okay, so that's a very quick overview of the conduct of implementation trials. Happy to take questions.
Does anyone have any questions or any questions online?
Share the screen.
Yeah, Vanessa.
Thanks, Luke. Always fabulous. But I've got a question that's not necessarily around the design of implementation studies and RCTs, more so around the sale of them. Because one thing I've noticed, having had the clinical trial and cohort results out this week, is if you put in a clinical trial into that scheme, what you're going to get funded is a large-scale, multi-centre, huge number RCT that's part of the Clinical Trials Club. Similarly, in other rounds, I've had kind of people not really who are reviewing the grants have this fantastic understanding of implementation research. So how do you effectively write a grant that is true to what you're doing, that you're going to be able to get funded by people who are not implementation scientists?
Yes, I mean, I don't often submit into that clinical trial cohort scheme. Perhaps I can just tell you where the places that we are most likely to get funding from and what we think the attributes of a good grant in those schemes are. So the partnership scheme is probably the most obvious. So you're often obviously looking to change the care or the practice of an organisation, and working with that organisation to develop a strategy for that to occur, and then having the organisation put some skin in the game and some money up to leverage in the context of the partnership grant is where they're kind of committing to implementing whatever it is, whatever the finding of the trial is, has been, we've found that to be quite a rich opportunity, a source of funds for this type of work. And in some rounds, partnership scheme success rates can be, 40%.
Yeah, much better.
Much better than trying to win a grant in other schemes in HMRC. The other is MRFF, so that seems to be a scheme highly geared towards translation and implementations of very translation-focused science. So we've had some success there. I think a couple of things that at least that we will often include in a grant that we think makes it scalable is kind of demonstrating the need, like the problem, of course, but more than that, the gap, like the fact that you have this evidence-based intervention and really good data to say that it's not being implemented and hasn't been, it's failed to launch. And so you've got a clear, what we call it, evidence practice gap, and good data to demonstrate that. And then good data around the feasibility of the solution that you're offering up. So that the implementation strategy you developed was thoughtful and co-developed and some pilot data, and that it's is not localized. So it's not only going to work in the clinic that you're doing the study in. These barriers, these ubiquitous across the sector or the setting that you're working in, and that the solution that you're generating is kind of scalable. Like the implementation strategies that you use leverage existing infrastructure, so existing workforce infrastructure, existing systems like prompts and reminders, existing. So these things can be kind of transformed so that care not just in a clinic where trials been undertaken, but the entire, the state of the system. Yeah. What's your background for? Got out what you were.
Yeah, I guess it's a bit comforting to hear that. I had another question if no one else did that. And anyone else?
I've got it.
Okay, I can cover.
So I guess for somebody who might be possibly thinking of an implementation trial, is there someone like in your unit or something you can go to for mentoring support before we go off, madly doing the wrong thing? Right?
I mean, I can't speak for individuals, but broadly the group is really receptive to speaking to people locally about, or to anyone really, about implementation research and how it's done. And we have a training institute where we train and mentor people from across Australia and across the world around implementation science. So I guess I just encourage you can contact me directly if you like, or I can put you in contact with others. But more than happy to have as many conversations as is needed. The other obvious place is by John Wiggers and the translation group that he leads, which actually has that role of supporting and mentoring and fostering research which is going to benefit the health service, much of which is implementation or health service research alike.
Vanessa, did you want to ask your other question?
So logic models and frameworks. In terms of the logic models, can you offer some examples of those? And so I know what logic model is, and I guess if you look at the FAID framework for impact, that's a logic model, but for implementation, is that similar or is it?
Yes. So I call FAID a macro logic model. So it's it's looking at kind of big processes and broad pathways to impact, which I think is really good when applied at often a program of work, rather. I think when I'm talking about logic models here, and probably I'm more talking about program theory, I'm talking about very discrete things that are driving the effect of your intervention. So if you're selecting, just as a very simple example, like you would select training if skill was the barrier that you identified. And so there are 73 possible implementation strategies. They're kind of been catalogued at the moment. There's 73 strategies that they're part of the taxonomy, and there are. I probably should have shown it during this. There are matrices that say, well, if you have these barriers, these are the possible implementation strategies that you could use to overcome them.
So like the TDF.
Well, exactly like TDF, yep. And so you kind of, usually what you do is you form your program theory by using those matrices that kind of do that linking for you, and talking to the people, the staff on the ground about whether this would work. And then you then usually try to pick up a measure that measures that thing, that construct. So it's knowledge or skill, something that's going to measure knowledge. And that will be one pathway by which you're thinking that clinicians are going to prescribe that or something.
Mm-hmm.
And so you essentially, that's essentially the process that you kind of go through. And often single events like training can often need a range of, you can package a number of behaviour change strategies or implementation strategies in a single entity like training. So yes, that's how we typically do it.
So I guess you're leading on from that question around process. Before we can kind of jump in and develop implementation strategies, we sort of need to do some groundwork in terms of identifying barriers. What's your, I guess, advice on how we get started on that and looking at what we need to implement?
So obviously you just have to speak a lot with the people whose behaviour it is that you're trying to change, and try and identify what, who needs to do what differently in order for improvement to occur. So often what we recommend, there are validated instruments to do that if you're interested in quantitative work, to identify what the barriers might be, using a questionnaire like the TDF or the domains framework. But usually that gives you a pretty precise idea of what the hell's going on in a clinic. And so you really have to, get your hands dirty and go in there and observe what happens, and do a bit of, informal ethnography, and triangulate some quantitative stuff, some qualitative work that you might do with the individuals who are involved in the change process. So that's usually, if you're trying to change clinicians' practice, it's definitely the clinicians, but it might also be the hospital managers or pharmacy, and so there are methods called process mapping that can help you identify who's involved in the change process, and getting around to those people and looking at what they do and what the drivers are, and what may be the impediments to the change that you're proposing, and then getting them to solve that with you. It's probably a really important process. And then the reality of enacting the change compared to the thinking about what problems or barriers the change may present are two completely different things. And one of the biggest, I think, in my view, one of the reasons why many of the implementation trials have such modest effects is that they do a lot of pre-work, and they might or may not assess barriers before the change is experienced, and they'll develop their entire implementation strategy based on that, and they'll let it run for a year and a half, and then they'll measure it and they'll tell you about whether it worked or not. But when you ask people what the barriers are or behaviour which they haven't tried, they're guessing. And so what we know is barriers are dynamic, and usually you'll have to adapt the intervention in some way, the implementation strategy in some way in the context of its delivery. So you usually need to repeat that process.
And all that work happens before you put the grant in?
No, so when we're doing grants, we'll usually have, just that formative work, that barrier assessment kind of formative work, and we will have some information about the feasibility, but the acceptability of the proposed changes. That's what we'll start with. So we're saying, well, we know what the barriers are, at least pre-implementation, and the package of implementation strategies that we've developed is feasible and acceptable to the group that we're working with, or the areas that we're working with, so then when we articulate, we don't usually go into the dynamic part, because that also raises design attribution type questions.
So just related to that, when you're talking about the acceptability of the proposed change, does that mean you're presenting, you've already sort of got a thought about what the change would be that you're presenting to the people that you want the behaviour to change in?
Yeah, so usually you're coming with a evidence-based intervention, or the clinic has come to you and they might say, tobacco use is a problem, all our patients smoke, no one's providing preventive care, and because so we don't know what to do, so can you help us out? And so we will often kind of go in and talk to them about, well, these are the clinical practice guidelines regarding preventive care, includes tobacco, includes smoking cessation advice, brief intervention, NRT and referral. And we might get their views about that intervention. So they might think, I don't do that because I don't think it works. I've been doing this forever, you've been doing this forever, and the same people come in and it's fine. So you want to get some assessment of what they think of the intervention. Because you'll need that as part of your implementation strategy. Usually they're kind of on board, they just have a reason that they don't do it, they're too busy, or there's other priorities in the clinic, or the NRT takes too long to get NRT delivery in the pharmacy, or so usually you have to have a good understanding of why that behaviour isn't occurring, so why that change, and then work with them on possible solutions. So you might say, well, if we got the NRT already charted and it was actually on site and at the desk, then you'd be more likely to deliver it. Or if we provide you with training or audit feedback, and you have a system of audit feedback already, and could we integrate into that? What would that look like? So you kind of workshop, I guess, the potential solutions. But your solutions have to be linked to the replay. It's easy to come with solutions that aren't linked to the problem. So most people will say, well, let's provide some training. We just train people and give them information that they need, they'll be more likely to do it. We actually know that never happens. So we know that doesn't work, even though we do it all the time. So it is really about that behavioural diagnosis, having a good understanding of why behaviour is not occurring, and matching the strategies tightly to that diagnosis.
Do we have any other questions in the room? Oh, hang on, I've got a Q&A. Hi, Arwell.
So Arwell says, thanks for your presentation, Luke. My question is also around the pitch of implementation trials. In a previous MRFF proposal, I feel that our type 2 hybrid effectiveness implementation design didn't go down well with reviewers. Any experience or tips for such proposals where there is a co-primary aim?
Yeah, I mean, I think that one of the issues is it's kind of an emerging discipline, and so terms like hybrid might be unfamiliar to a lot of people. I've also seen the reverse. Like we've put in trials where it's not a hybrid trial; it's just an implementation trial. Like we're not measuring, and we've had critical comments back that it wasn't a hybrid, and they're not even using the hybrid terms, and we thought, well, it's not a hybrid because you don't need to do a hybrid. And probably the learning is you probably just have to educate the reviewer on what a hybrid trial is and why it's important. And if you're proposing a hybrid too, then you have to make a strong case that the effectiveness of the intervention is not well established, and the effectiveness of the implementation strategy is also unknown or not well established. And so it might just be you have to kind of take the reviewer on the journey and assume that there's no prior knowledge around implementation.
On that, is there a risk of pitching a hybrid trial because if phase 1 isn't effective, then you've got nothing to implement?
Yes, so they're called effectiveness implementation trials. So usually there is some efficacy data. So there is some efficacy data that this new innovation is beneficial, but you just don't know whether it works in the real world. And so I don't think I'd recommend a hybrid trial if it's never been tested before, because there's reasons why we have efficacy trials. They need safe conditions, they need good monitoring and oversight. So that work should have been done, and really you're kind of saying we don't know we don't know if it's going to work in the real world, particularly with the, and we don't know whether that we can get an improvement in implementation sufficient enough to retain the therapeutic benefit.
So this is the Centre of Treatable Traits, and I know you're familiar with treatable traits. So with this, what we're looking to do is, do models of care that are personalised care based on evident traits in individuals and personalised interventions. So we might have 30 traits that is in one person. That's not likely.
Yeah.
Like for someone with severe COPD and severe asthma, it's 10. Now, those interventions largely are supported by evidence-based treatments. The model of care, however, hasn't necessarily been trialled in large-scale RCTs.
Yeah.
What do you think we need to do about this? Do we do large-scale efficacy RCTs of models of care, or do we do implementation studies of models of care?
So just so I got this right, so do you know? So for the 30 or so traits, there are already like clinical practice guidelines about what should be done to address each of those.
Each trait.
Yeah, and do you know that that care isn't being provided? Like if there's a gap, so that is not happening routinely.
Yes.
So if that's the case, like I would, and so for an individual patient that comes in, sometimes they might get they might have 2 traits. So the care is going to look different because it's personalised for every.
Yes.
So in my head, I went, you probably want in an implementation trial, you probably want some measure of guideline concordant care. So it's about consistency with guidelines rather than did they get A, B, or C. But it sounds as though if you've got good evidence of therapeutic benefit, then I would be moving to the implementation trial. Yeah.
Great answer. That's what I wanted to hear.
Alright, if we have no more questions online, I'll just give one last chance if you would have got any questions in the Q&A box just quickly. Any more questions in the room before we wrap up? Any questions online?
Sadly, no.
Alrighty, well, I'd just like to thank you again, Luke, for coming and talking to us. So I think everyone today has had a good presentation, and hopefully we can move forward and whether we can approach you if we do have any further questions. That's great to know. So yeah, if no other questions, this webinar will be available on the CRE Treatable Traits website. So yeah, I'd like to, if you can all join me in thanking Luke and everyone for listening.